This is a session about proctology, because as a gastroenterologist we are often confronted with these patients. It will be very case-based. We'll look into how to approach anal pain, and we'll also focus on the special situation of pregnancy. We start presenting, we don't have any disclosures related to this session. Okay, we start with the first patient, who is Betty. She's 20 years of age. She has no medical history, but she is pregnant. And now we are at our week 34 of pregnancy, and she comes first to the gynecologist, who sends her to you with a very a lot of pain anally and an anal swelling. And that's the image that you see. And the question is, of course, what do you see here? Do you see a cancer? Do you see an external hemorrhoidal thrombosis? Do you see an internal hemorrhoidal thrombosis? Or do you just see internal and external hemorrhoids that are painful? You can start voting. We'll see if we are getting results. Okay. Okay, well, we are getting a lot of results, and okay, maybe we can show the results already, because we see that everybody calls this an external hemorrhoidal thrombosis. I'm going to continue because I do not agree. And why do I not agree? Because you have to look very carefully to this lesion. And there you see what I demark with the red. That's edema. So this is not a thrombosis, what you see here. This is edema. And the thrombosis is in the middle. And in fact, this is an internal hemorrhoid that protrudes through the anus, and that in this situation got thrombosed. Now the next question for you is, how do we treat this? How would you treat this young lady? Conservative or surgical therapy? Incision, excision, whatever. So it's up to you again to vote. Okay, let's have a look at the results of the voting. Yes, and okay, here we see some different answers. We see that the majority would do some surgery. 1/3 would treat this patient conservatively. So you see that the hemorrhoids can have a big political consequence. Okay, that was the end of the intermezzo. Betty is now 28 years still, but we are a couple of months later after she has given birth, and she develops 1 month after this the partus, she develops anal pain again. She's being treated with some ointment, with lidocaine and triamcinolone, because her generalist thinks she has hemorrhoids. And 4 months later, she comes to the gastroenterologist because of ongoing anal pain and some blood loss. And of course, her question is, will you help me from these hemorrhoids that keep bothering me? This is what you see when you look to Betty's anus at this moment. But if we do some better questioning, we hear that the pain is caused by defecation. But well, we are going to show you, if you have a good examination of your patient, the left panel is just like that. But if you defold very nicely the folds of the anus, there you see that she has even 2 fissures, anal fissures at both the midlines, and anal fissure is of course the most important cause of anal pain caused by defecation. Isn't it, Hannes? Hannes Rembeke is also our colleague, who is also doing together with us the proctology at this department. Hannes, what? This is Patrick, who is 34 years of age. He's HIV positive, but he's being treated. He has an undetectable viral load. His CD4 count is normal. And the reason why he consults is because of 1 week constant urge to defecate. He can only pass some mucus, some blood, and it becomes painful. He has rectal pressure all the time. There are no abdominal complaints, and on the clinical examination, inspection and the digital rectal are normal. The rectal examination is painful, and we do a anoscopy or proctoscopy, and that's what we see. Maybe Jeroen, that you can describe the lesions that we see here.
So this is an image of the rectum, and what you clearly see, this is not normal mucosa. For me, this is a rectitis. It's bloody. There's no clear vascular pattern. There's clear erosions, even some ulcers, as you indicate now in the white area there. So there's a clear ulcerative rectitis going on just by the view of it. So this is just a description, not the diagnosis.
So what we see is that 1/3 would put an elastic band, another third some minimal invasive surgery, and whoops, this changed a little bit, and some 40% would do first 44, 45. Okay, great. Well, this is changing all the time, but okay, great. Okay, but in fact, the answer is, if I would have asked you the question, you have a 50-year-old patient, a 54-year-old patient who has blood loss and who has a change in defecation pattern, then the answer, first do a colonoscopy, would have been 100%. Of course, this patient clearly has a hemorrhoid, but this doesn't matter. Yeah, you can give me the French, they say, un train peut en cacher un autre. I'm saying this in English now. So, you know, you have to look out, because it's not that this patient, indeed, she has grade 4 internal hemorrhoids, but that doesn't exclude her for having a colon cancer or a big polyp. So you always have to do a colonoscopy in someone with blood loss above 45 years old. And so now comes, of course, the question. What do you do next? You think this is an anal fissure that I don't see, and you treat it, or you do an endoscopic ultrasound, or you send him for an MRI 1 month later or something, or you take him to the operating theater for exploration under general anesthesia. Okay, that may be a bit more difficult, but we will see. They're coming. Yes, I have to keep on talking, but well. Of course, if you give an answer, you also have to think, why do I do this? And if we would have a live audience, of course, we would ask you, why did you choose for whatever example that you're going to take? But I see that we have a very, very good audience here, because everybody is going to explore this patient under general anesthesia. And now, of course, I would ask you, what do you think? And then probably you would all say that you think this is an abscess. And in fact, I did during the consultation, I did an endoscopic ultrasound.